Assalamualaikum Pak Ujang.
Salam, Pak.
Ya, seperti biasa Pak ya, nanti
Di ruangan ini ruang dekanat, Pak.
Oh ya, nanti pas ini apanya live YouTube-nya udah dimulai Pak?
Sudah, cuma musik aja, Pak. Ada lah, saya matiin aja dulu. Di ini di takut ini lagi.
Ya. Jam berapa Pak dari ini kampus, dari rumah?
Jam 6 naik motor ngebut. Soalnya nyonya pakai mobil, jadi sekarang udah biasa di rumah.
Nanti pas saya ini Pak ya, kita mulai langsung YouTube-nya dibuka Pak ya, atau saya bilang Pak Ujang mulai, langsung gitu ya.
Ya Pak.
Seperti kemarin lah, Pak Ujang mulai gitu.
Baterainya habis.
Oh baterai habis Pak.
Oh ya, bisa. Bisa Pak di itu dulu, di stop dulu, setelah stop di ini lagi, jalanin lagi.
Ada berita apa-apa tentang apa tu? MOU kita, MOU. Ada apa cerita? Belum lagi. Ya.
Oh, belum, Prof.
Okey. Saya sudah hubungi Dr. Rina. Ya.
Ya, Prof. Boleh kita mulai aja, Pak Ujang?
Ya, boleh. Silakan.
Ya, Prof.
Ya, silakan.
MOU kita, MOU. Ada apa cerita? Belum lagi. Ya.
Ya, Prof. Ya, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good morning, ladies and gentlemen, and all students. The theme of our lecture today, Etnomedicine and Etnopsychiatry. At the first glance and the given introduction, a little related from of the theme, health of the anthropology, about the discipline anthropology is the after of the end War II. The many aspect, and then the anthropology and the biological and anthropology and the cross culture studies, and then the Etnomedicine is at the health anthropology according to the poster and the understand the Etnomedicine is believed in a practice to related a disease, and then Etnomedicine is the result of the indigenous culture, and then the development explicit, and then does come from the conceptual and the attention and anthropologists and recording, not Western and the medical system, include the health, magic, and the religion. And then the anthropology, the aspect the ethnopsychiatry and the mass as a comment, the ability and listen from the example is the critical and the discipline psychoanalysis afford the mental illness to the listen and the vision and the understanding the structure and the symptom original and the understanding the define. And then thank you very much for the Professor Madya, Dr. Nur Azlan, who the agreement to hear the guest lecture today. Please, Prof. Madya, Dr. Azlan, to the presentation to 60 minutes and 30 minutes to the question answer.
Okay.
Thank you.
Thank you. Thank you, Dr. Junadi Harahap, as the head department for anthropology department. At the same time, I would like also to take this opportunity to thank the University Pajajaran Bandung, particularly students from Studi Anthropology Fakultas Ilmu Sosial dan Ilmu Politik Universitas Pajajaran Bandung, Indonesia. Okay. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Selamat pagi, selamat siang ya di sana. Dan pertama sekali kita memanjatkan kesyukuran kepada Allah Subhanahu Wa Taala kerana memberi ruang kita, memberi kita ruang untuk kita bersama pada pagi ini untuk program ini, dan moga-moga Allah memberkati usaha kita. Dan saya juga mengalung-alungkan ucapan selamat hari raya juga kepada semua, kepada Bapak Dr. Junaidi Harahap dan juga staf akademik yang ada di Universiti Pelajaran Bandung. Okay, Alhamdulillah, for today's presentation, I'll be delivering a lecture on ethnomedicine and ethnopsychiatry. So I'm going to share my slides. Hopefully it works. Okay, let me see what I can do. Ini kalau teknikal ni saya agak lemah ni. Sekejap. Okay. Masih loading, insyaAllah. Okay. Okay, saya kira macam mana ni ya? Share ni. Share, sekejap ya. Okay. Kelihatan tak sekarang? Dapat dah ya?
Okay, bro.
Okay. Okay, insyaAllah. Alright, okay. My content of my presentation this morning will be around 5 to 6 topics: anthropology and psychiatry. And topic 2 will be normality in mental health. Third point will be perceptions of social behavior. Fourth will be ethnographic description of psychiatric illness. 5 will be psychiatry and law. And finally, go for conclusion. Okay, before I go into the details on anthropology, so let's begin with anthropology and psychiatry. So what can I say about this? So, I have to admit, that this fact, the anthropology is ambitious in its theoretical scope. So the definition of anthropology as science of man or mankind in the widest perspective implies the holistic concept and approach the discipline wishes to have or to bear. So we are a bit ambitious. So we want to study the holistic, to understand anthropology in the widest perspective. And for anthropologists, we would like to understand human behavior or understand the science of man setting in a natural setting. So we would like to observe them in a natural setting, and that will be our priority, and also the utmost preference as far as anthropology is concerned. So at the very beginning, you look at the anthropology, at the very beginning, the object of anthropological investigation were the others, or maybe different ones, or sometimes we used to say, it's a bit ethnocentric to say this. Anthropologists would like to study people in a primitive setting, or we can say primitive people. That was the early days of the development of anthropology. Today, anthropology are no longer focusing on non-Western or primitive communities only, but also subcultures within the Western society or within the current society. So you can see here in this diagram, so anthropology, the traditional anthropology, the area of investigation, mostly societies of non-Western peoples. You can see the development of anthropology at the initial stage do take into account of behaviors or social relationship in the context of non-Western people, or we can say primitive community, and a bit ethnocentric to say that. But today, present day, and to the area of investigation, we talk about societies and social structures of all peoples, irrespective whether you're talking about the primitive community or whether you're talking about non-Western society or whether you're talking about modern society. All this will be under investigation. And based on that, so as a conclusion for this particular display, we have this multidisciplinary context of anthropology here. So we have multidisciplinary structure of anthropology and its components. So we have biological anthropology, we have cultural anthropology, we have anthropological linguistics, we have archaeology, and applied anthropology. These are, so I could say, these are the main branches of anthropology with the current situation. So that means every area, biological anthropology or cultural anthropology, they do have their own interests, and they do have their own theoretical orientation with regard to their subject matter. Now let's look at the area of methods covered in a psychiatric study. So, what do you mean by psychiatric here? So, psychiatry is a branch of medicine, the domain and content of which is the examination, diagnosis, treatment, and prevention of mental disturbances, related conditions, and behavioral disorders. So, you are talking about something to do with mental disorders and related conditions and behavioral disorders. So that means psychiatry will study, will do the study, and at the same time will do the diagnosis and treatment and prevention. Any methods related to mental disorders and related conditions and behavioral disorders. So that means, in other words, when we talk about ethnocentric, or we talk about ethnomedicine, where ethnomedicine, if I could say in the simplest form, we are talking about the medical system that represents one particular group. So the word ethno means tribe, or it can be a community, it can be a society. So you say ethnomedicine, you are referring to a medical system within that particular society. It can be, and we used to say the traditional medical system, like orang asli, the traditional Malay medicine, the traditional Chinese medicine, Indian medicine, Ayurveda, or you can have the Chinese medicine, and even hospital medicine. Sometimes certain books will say even the Western medicines can be ethnomedicines too. So the modern medicines can be part of ethnomedicine too, because it symbolizes one particular community, which is Western societies. But I'm not going to go into that kind of debate. So in general, we say ethnomedicine is a medical system representing one particular group. Okay, and normally we used to have this clear dichotomy between modern medicine and traditional medicine. And then ethnopsychiatry is one of the area that we get to look into under this ethnomedicine. So ethnomedicine, you're talking about, ethnopsychiatry means you're talking about psychiatric issues encountered in that particular community. Ethno means tribe or group, and psychiatry means the whatever issues related to mental disorders, and that we can encounter in that particular community, right? So then they, because of to say psychiatry alone is a branch of medicine, and of course the domain or the principle used by psychiatrists could be biological framework. But what we are talking about ethnopsychiatry is more a bit of like cultural psychiatry. That means a special field. Cultural psychiatry is a special field of psychiatry which is primarily concerned with the cultural aspects of human behavior, mental health, psychopathology, and treatment. So the key word here is about the cultural aspects of human behavior. And if you look at the clinical level, cultural psychiatry aims at promoting culturally relevant mental health care for patients of diverse ethnic or cultural backgrounds. That would be in terms, if you look at these psychiatric issues at the clinical level. So in terms of research, what will be our focus in terms of research? Cultural psychology, cultural psychiatry is very much interested in how ethnic and cultural factors may influence human behavior and psychopathology, and as well as the art of healing. So that means, so in a way, cultural psychiatry is focusing on the cultural aspects of human behavior, mental health, and psychology, psychopathology, and the treatment. So on the theoretical level, cultural psychiatry aims at expanding our knowledge of human behavior, and cultural psychiatry aims to expand not just the knowledge of human behavior, but at the same time to expand the knowledge of mental problems and transculturally. Okay, that means in order to see to what extent these cultural aspects of psychiatry can be adopted or can be explained further in a Western psychiatric framework. Right? So sometimes the Western psychiatrists, they do have their own protocol, they do have their own frameworks to understand others. But at the same time, we anthropologists, medical anthropologists, we do have our own methods to understand the psychiatric issues within that particular community. And there are terms, there are protocol which is adopted by the Western psychiatrists, which does not fit into the psychiatric issues faced by the community itself. So because of that, the Western psychiatrists will have to curate or to come up with a new list and to explain further of these cultural psychiatric issues. So in other words, so you can see here there will be some kind of relationship between anthropology and psychiatry. So you can see this diagram, anthropology, and then inside the circle, the main is a biological anthropology, and then these biological issues can be further expanded, can be further elaborated or analyzed using cultural anthropological approach. Okay? This kind of a simplistic figure, I could say here. And then you have a psychiatry there, and the core business here is about how we go about understanding psychiatry issues in cultural context. So in other words, we are talking about cultural construction of psychiatry issues, and then surrounded by social psychiatry. So we are not talking about psychiatry in its own sense in terms of biomedical approach. In other words, we need to see psychiatric issues in a different perspective, not just relying very much on the biomedical framework, but at the same time, we need to see things from the ethnomedical framework. Okay, ethnomedical framework. So this, you can see the focus here. So the focus in the case of ethnopsychiatry, we are talking about the role of culture in shaping or in determining the psychiatric issues in the community. So that means the main contribution. So we can say at this level, anthropology and psychiatry. Okay, I mean anthropology has contributed to psychiatry both at the theoretical level and also at the practical level. And then we're going to have a kind of integrated methodology here. So you can see anthropologists, they do have their own strength as far as methodology is concerned. Psychiatrists, they do have their own methods to understand psychiatric issues. So when you have these two disciplines being together, that means we can see the contribution of these two disciplines to understand the psychiatric issues in the society can be enormous. And so the main contribution of anthropology to psychiatry consists of emphasizing the relevance of social environment in the diagnosis, treatment, and prognosis, as well as in creating concepts and methods that psychiatrists are able to apply. So that means this will be, I could say, contributions that could be made by studying anthropology. We are able to understand the psychiatric issues in the community in a wider perspective. I mean, in terms of diagnosis, in terms of providing treatment, at the same time, in terms of understanding the prognosis of the case. Then, so this is in a way, I could say, again, we're talking about the frameworks that we should have. That means we're talking about biomedical framework, of which you're talking about biological principle of curing disease. But at the same time, you have ethnomedical framework, of which social, cultural, and religious principle deals with healing the illness. So you can see under biomedical framework, they are more discussing methods relating to curing disease. They are talking about to cure the disease. But in ethnomedical framework, we are not talking about, we are not just limit ourselves curing the disease. We are talking about healing the illness, the art of healing. So the keyword disease and illness here. All right. So so that means before we go to the second part. So in other words, a key starting difference between the two, between the psychiatry and anthropology, will be anthropologists' interest in relativism, whereas psychiatry has been interested in universalism. What does it mean by this particular statement? So anthropologists' interests are more to relativism. We are given to understand the case, or we have to understand the psychiatric issues as it is in the community. You are talking about either you are going to use amic categories, okay, not so much on ethic categories. So you're going to see the explanation of psychiatrists from the community itself, the amic categories. And then, but for psychiatry, their main concern is about universalism, interested in universalism, how to understand the psychiatric issues across the society, irrespective of modern or rural or primitive. How do you fit into their psychiatric model? Okay, which you say they have their own protocol and modules about psychiatric issues, and they wish to have all those psychiatric issues in other community can be explained using their universal protocol, universal framework. So both disciplines, anthropology and psychiatry, contribute to the philosophical questions of meaning experience raised by cultural diversity in mental illness and healing. So why anthropology? Why anthropology needs psychiatry, and why both anthropology and psychiatry needs each other. Number one, okay, of course you look at here psychiatry using the biomedical framework and ethnomedical. You can use both frameworks. Why anthropology and psychiatry needs each other? Number one, okay, to make sense of intra-cultural differences in beliefs and behaviors. So one of the things that we need to know here, by having these two disciplines together to address the psychiatric issues in the community, we are able to make sense. We can rationalize the intra-cultural differences in beliefs and behaviors. And we can also explain the personality differences that could be affected by certain cultural issues or values or beliefs. That would be number one. The second reason why we need each other, because of the limitation of the psychiatry. Meaning, I'm not saying that limitation in a negative sense. What I'm trying to say here, limitation of psychiatry in understanding relationship between cultural and psychopathological aspects of experience. Okay, so that means there are certain things where the psychiatrist can deal with, but there are certain issues of psychiatric issues that could be beyond the knowledge. Not to say they don't have the knowledge, but how we go about redefining or recategorize or relabeling certain psychiatric issues observed in the non-Western community, which maybe those psychiatric issues or the mental issues faced by the non-Western community could not fit into the Western psychiatric model. That would be the second reasons why we need each other. The third reason is because cultural formulation method. This is the strength of anthropologists, and the strength of anthropology, or the strength of us as being anthropologists or medical anthropologists, to formulate, to address those issues using cultural formulation method. Okay, so because we are strong in identifying, we are strong in explaining the cultural issues in the community, right? That would be the third reason I could say why we need anthropology and psychiatry together. And finally, number four, why both anthropology and psychiatry needs each other, because anthropology also provides psychiatry with knowledge pertinent to a global perspective of mental health, right? That means anthropology emphasizes or presses and anthropology wishes that psychiatry to engage knowledge based in non-Western society. So that means as of now, maybe psychiatrists, they are more concerned of the Western society. So they're not focusing into the non-Western community. But out there, at the global level, so there are many psychiatric issues faced by other community out there that need to be addressed, not just by psychiatric methods, not just from the psychiatric theoretical orientation, but we need to have both anthropology and psychiatry in terms of delivering an effective kind of results. To make the findings more effective, and to make our diagnosis, treatment, and prognosis will be very much effective. So based on the above reasons, the 4 reasons which I mentioned just now, the role of culture in reframing psychiatric issues is evident, is imperative. So the role of culture in reframing psychiatric issues is our priority, is very important, is imperative, or is evident. So that means, thus we could state that the cross-cultural study, the cross-cultural psychiatry or ethnopsychiatry, is the study and comparison of mental illness in different cultures. So there, from this particular point, we can start saying that the ethnopsychiatry is a study, is a comparative study about mental illness in different cultures. So when we are still in this particular slide, okay, when we talk about, when we look at these 2 diagrams here, the biomedical framework, ethnomedical framework, in relation to psychiatric issues, it tells us that from this framework, it gives us a clue that we can do research by, from here we can see there are 2 types of investigator, or there are 2 types of researchers here. One is the Western trained psychiatrists. The Western trained psychiatrists, they will subscribe to biological principle, and in other words, they will subscribe to this biomedical framework, in which biological principle is the authority. Okay, so you can see they start using reductionist approach in understanding disease or illness. So in other words, of course, Western trained psychiatrists, they are not familiar with certain things in the non-Western community. So maybe they come across over symptoms of psychological disturbance in the non-Western world. They try to understand those symptoms, but they could not. So in other words, maybe they try to see, let's say when they talk about hallucination, they talk about delusion. They try very much to explain to their basic biological science concept like schizophrenia, post-traumatic stress disorder, manic depression, or bipolar disorder. So sometimes this term is not applicable in the context of non-Western society. So the second investigator will be the medical anthropologist or social anthropologist. They, in this case, for medical anthropologists or social anthropologists, their main interest will be defining the concept of normality versus abnormality in different cultures. So you can see in the biomedical framework, they were talking about the medical term like schizophrenia, hallucination, depression, bipolar disorder, PTSD, whatever, obsessive, dissociation, all these are biomedical terms. But for medical anthropologists, We're not saying that we disagree with all these terms, but most of the time, medical anthropologists will be talking about the concept of normality, the concept of abnormality. So how we go about understanding this concept of normality and abnormality in different cultures. So in other words, the focus of ethnopsychiatry or cross-cultural psychiatry is mainly on mental illness, and rather than on mental disease. So you can see a clear, I could say, a clear distinction between the ethnomedical interest and the biomedical interest. So if you adopt biomedical framework as your framework, or that will be your theoretical orientation, then you will try to understand the psychiatric issues in the non-Western community using all the biomedical terms. And most of the time, the focus is how to address mental disease. But in the case of anthropologists or medical anthropologists or ethnopsychiatrists, for ethnopsychiatrists, maybe perhaps they were talking about the concept of normality and abnormality. And in this case, they are more concerned about mental illness. Yes, mental illness. Okay, I need to, sorry, saya kena plug sikit battery. Okay, my battery is running low. Okay, now I already fixed up. So this brings me, by looking at mental illness and mental disease, this brings me to explore further of ethnopsychiatric issues. There are two domains which I already addressed here relating to ethnopsychiatry. Number one, the biomedical domain of inquiry. The second will be the ethnomedical domain of inquiry. So ethnomedical domain of inquiry and biomedical domain of inquiry. So that means the word ethno, which I already mentioned here, came from the Greek term ethno, which means tribe. And we do have these terms that based on the word ethno, we have many terms attached to this prefix ethno. We have ethnography, we have ethnology, we have all these tell us about cross-cultural analysis about certain issues. Okay, so that means since so when you say ethno psychiatry, or you say ethnology or ethnography, okay, the main agenda here is about cultural structuring. You're talking about cultural reframing or cultural structuring of all knowledge and experience. And that is what we mean, that is what we meant by the word ethno here. So we say ethnography, ethnology, and in this case, for today's lecture, to talk about ethnopsychiatry. So we are talking about the or ethnomedicine or ethnopharmacology. There are many terms attached to this prefix ethno. So in short, we can say whenever we do have these terms attached to the discipline like ethnopsychiatry, we are talking about cultural structuring or culture reframing of all knowledge and experience. So, so in other words, ethnopsychiatry addresses cultural. So now we can go down a little bit down further here. Ethnopsychiatry. In other words, ethnopsychiatry here means you're talking about addressing cultural aspects of mental disorders. Okay, cultural aspects of mental disorder. So medical anthropologists, in this particular case, are more interested in how cultural factors affecting the patient's perceptions, affecting the patient's behavior. Or sometimes we have the word illness behavior, right? So the content of hallucinations or the content of delusions and attitudes of others toward the patient. So in general, the relationship between culture and mental illness, or in the relationship of culture to mental illness, can be summarized, can be concluded in as follows, right? Number one, we can talk about defining normality and abnormality in a particular society. Number two, we are talking about etiology. Etiology or cause of certain illnesses. Of course, in this case, we are talking about psychiatric illness. The third, we talk about the clinical presentation or distribution of mental illness. And the fourth, we talk about the ways the mental illness is being labeled, being recognized, being explained, or being treated by the members of that particular community. So this is the relationship between cultural aspects to mental illness. So now we go a bit detail. So what do you mean by normality in mental health? How do you see this normality in mental health? Okay, normality, so we have to define mental. So the table this below shows us about there are many models talking about normality as health. So if we talk about medical model, then the normal mental health is conceptualized as the absence of any psychiatric disorder or disease or psychopathology. You're talking about the absence of any psychiatric disorder because they talk about medical disease. They talk about mental disease. So normality and the medical model, you are free from all those diseases. Or you can also adopt this utopian model. And under this utopian model, normality means the focus is in defining normality as an optimal functioning. So you're talking about the functions of your mind, the functions of the brain here. Okay, we do have the capacity, the maximum capacity in terms of functioning of the brain. So sometimes sometimes people would say the person is not normal, right? Because of he or she is suffering from certain kind of mental disease, like meningitis or whatever, all right? That some rather reduce the functions of the brain. Or you can also talk about normality using subjective model. So normality in this particular case and this particular model will be as an absence of distress, absence of disability, or any help-seeking behavior resulting with thereof. So in other words, this subjective model is very much similar to the medical model. Or you can also have another model, social model. So the normality concept here means a normal person, according to this definition, is expected to behave in a socially acceptable behavior. In this case, you're talking about the whether your behavior is approved or disapproved. Okay, this is a social model. That means you're talking about the perceptions or the perceptions or the perceptions of the members in the community. So their expectation of you to behave accordingly within the approved norms in the community. Or you can also talk about normality as a process. So that means normality is not something static, but it's a dynamic, keep on changing over time. Okay, and finally, you can talk about normality as a continuum. Continuum means you're talking about the when you say continuum, you're talking about it's a straight line. Okay, observe. So so the concept of normality keeps on fluctuating. Yeah, at one time you can be at the utmost level, or sometimes you can be at the lowest level. So normality depends on which pole or which continent, which pole you are talking about. Either you're talking about positive side or negative side. So normality and mental disorder are considered by this model as falling at the two ends of a continuum rather than being disparate entities. Okay, so this is I could say what I call this the concept of normality versus abnormality. And so at the end of the day, okay, so we can say that normality in this, when we talk about psychiatric issues, we talk about the issue of appropriateness here. You're talking about the appropriateness means you're talking about how we explain our appropriateness behavior in context or in a social relationship. So this covers many things: personal hygiene, lifestyles, hairstyles, facial expression, tone of voice, and the use of language are all taken into account. So in other words, normality is usually a multi-dimensional concept. So that means, of course, when you talk about psychiatric issues, right, you are talking about the issues of appropriateness, kesesuaian, ataupun kewajaran in bahasa Malaysia. So, is it wajar, or is it appropriate for you to behave or to use that kind of language? Because from the language itself, people know whether you are in a stress mode, are you normal or not normal. So for people suffering from some kind of mental disorders, they were talking out of context sometimes. So you see there is a kind of you and reality is not very much engaged. So you have so-called the detached reality. You're talking something out of context, and because you are talking out of context, people say that you might be suffering from some kind of mental disorder, or you can orang gila, right? Or in that case. So in other words, although normality is not an easy concept to be defined, but somehow or other we do need some kind of traits here that can be found in normal individuals. What are the things that you consider as normal person? So at least there are some kind of features or characteristics that really meet the criteria of a normal person. Even though normality is a difficult concept to be defined, but certain traits need to be there. Number one, reality orientation. And that means you are well engaged in the reality of the surrounding. So a normal person means you are well engaged in the normal surrounding. If you detach yourself with the reality, so something is not right there, right? And then number two, another trait will be self-awareness and self-knowledge. You know who you are, right? Okay, that means for people suffering from mental disorder, they are not talking about detached reality. They do not know even themselves, right? So, but in this, for a normal person, you are aware that you are here. Okay, like myself, I'm aware now. I'm giving my lecture in Bandung now. I'm aware. Right? Self-awareness must be there, and self-knowledge. You know who you are, right? That's why you can see when someone made an accident, in a car accident. If you are brought to the hospital, the doctors will always ask you, right? Number one, you know where you are now. Okay, what is your name, right? Because when you made an accident, there will be a concussion, right? So sometimes you are out of context. So that means you are nowhere now. So the doctors would like to see to what extent are you within, are you normal person or otherwise. So that means the reality means, do you know your name? Do you know where you are? Do you know why you are here? Where are you going? So in other words, in this case, you are aware, self-awareness and self-knowledge. And number three, self-esteem and self-acceptance. I mean, you're talking about this third category of features for normal person: self-esteem and self-acceptance. And number four, ability to exercise voluntary control. You can control the behavior. Voluntarily, you can control the behavior. Number five, ability to form affectionate relationship, right? I mean, you to love and to be loved, right? So that's common, right? A normal person needs to be loved, and a normal person can fall in love to the other party. So that means ability, you have that kind of ability to form affectionate relationship, caring, right? For example, you care the person, you have the you look after a patient, okay, your caring attitude. And finally, number six, you must be able to pursuance of productive and goal-directed activities. You do your activities with certain what you call certain direction. Okay, it's not something in Malay called hala tuju. So in your life, you know how to go about, what to pursue and what not to pursue, right? And what kind of objectives you are willing to go for it, and what kind of objectives that you wish not to go for it. And it's all based on your ability as a normal person. We cannot do something beyond our ability, even though we can do it, but the results could be not encouraging in many ways. Okay, so, but again, the concept of appropriateness and acceptable behavior varies across the culture. It varies. For example, the concept, I'm sure you heard about latah. In the Malay community, you have latah. Latah is something, you might say something abnormal, but for certain community, latah is normal. Okay, right? You start to giggling, right? Or you have, let's say, trance state menurun in Malay. And this is the concept. You can control. Surprisingly, you can be in another world, talking to the other kind of being, supernatural being, but you are in a trance state. Okay, and for the Western psychiatrists, they would say this is a kind of mental disorder, but in reality, particularly in Malay culture, menurun or trance is normal. So we don't say something is abnormal, because the Pak Dukun, the Bomo, when he is in a trance state, he will talk something away from his everyday language. He will talk something else, particularly about treating the disease or illness that you are suffering. And after a while, he can come back. So at one time you become a little bit unconscious. Not to say unconscious, I use the word unconscious if I could use the word. At the same time, you can come back to the reality. So this is really something beyond the knowledge of psychiatrists. Okay, and then I mean, from those from the Western, from the biomedical framework, the concept of spirit possession. You're being possessed by the spirits, and suddenly you become hysteria, right? So it affects your mental, your mind. Okay, so in that case, how do you explain about this concept of abnormality? When people become hysteria, people start to scream for no good reason, and at the same time, after a while, you can come back to your normal life. A spirit possession, the spirits can enter into the body, and we can also talk to the spirits within the body, and we can also ask the spirit to leave the body. So it's quite something really, really extraordinary, and because it's beyond knowledge of it. So that is why anthropologists focuses more on relativism, understanding the subject matter within its own context. And the most important here is about to develop the amic categories rather than ethic categories. But for psychiatrists, they are much concerned about universalism. And we are talking about ethic categories rather than amic categories. They would like to transform the amic categories of psychiatric issues into ethic categories. So this, at this particular stage, there will be a mismatch, and sometimes it could not. And the concept they wish to have is not really fit into into their framework. All right. So now let's move on to the third part, third topic on perceptions of social behavior. So what do you observe under these perceptions of social behavior? So you can see a diagram here. I could say, diagram. That means you talk about control, normality, control, abnormality. You have what is uncontrolled, normality, and you have uncontrolled, abnormality. So this is something, what it's all about. It's about perception of social behavior. So here we talk about this is well represented. So where you can see, again, we talk about normality and abnormality. But the issue here, you have 4 different compartments, if I could use the word compartments here. So the compartment A, you talk about normality. But this is control normality. Okay? And then compartment B, you have abnormality, right? You talk about culture-bound syndrome, religious states, and symbolic inversions. Here we talk about control abnormality. And the third, and C, you talk about uncontrolled. Okay, you can see, maybe I can, you see the chart here. So you talk, see uncontrolled abnormality. mad, and you become mad. And then you have uncontrolled, you have bad, but uncontrolled. No, it's normal, but uncontrolled normal. So these are, I could say, the zones of social behavior mentioned in this figure, and those behaviors are not static, right? Those behaviors are not static; they are always dynamic in nature. So the four possible zones here represent the range of possible perceptions, whether they see it as normal or they see things as abnormal within the jurisdiction of the members in the community. All right, perception of the community here, whether you are normal or abnormal, control abnormal, uncontrolled normal, uncontrolled abnormal, all this depends on the perceptions of the community in the community. And the perceptions of the community lies very much on the jurisdiction of the members in the community. And again, the jurisdiction of the members of the community still depend on the three types of reasoning which I mentioned in my previous lecture. Either it be scientific reasoning, or whether it's going to be cultural reasoning, or whether it's going to be what I call this religious reasoning. All right. So, for example, let's say social. For example, let's say control normality. Control normality is not uniform within a community. I mean, most cultures have a wide range of definition and wide range of social norms, which are considered appropriate for different contexts. Okay, it depends on age. The context can be age, can be groups, can be gender, can be occupation, can be cultural beliefs. So the appropriateness, control normality, right? Maybe let's say marrying same-sex marriage, right? For example, maybe in our context, okay, it's not normal, all right. But to certain society, it is normal, right? It's not really issue if you declare yourself I'm a gay, you declare yourself I'm a lesbian, right? So in that particular context, to them it's normal, but to us it's not normal. So that's why I say it depends on the jurisdiction of the members in the community. And then you have this control abnormality. Control abnormality here we are talking about, it's really abnormal, but it's control. You know it is abnormal, but it is still control. Example, in the case of Malaysia, every year we have Thaipusam, right? So the Indians carrying the kawati, okay, heavy kawati, and most of them will be in a trance state, climbing the stairs to meet their lord of Murugan, their deity. Or you can see in a Western culture, Halloween, right? So they put on the dress because to celebrate Halloween. They also celebrate, for example, New Year, right? They celebrate April Fools, right? So all these are considered as control abnormality. So believe in spirits, and believe in body. Body means the evil spirits emanating from the dead body. Possession is abnormal, right, for individual behavior, but it confirms by the cultural values and norm. So all these are considered abnormal, but in control. So that means what I'm trying to say here is that every society, they have their own spectrum. Okay, spectrum in terms of the range between control normality to control abnormality. That will be A and B, which I already discussed. What about C here? C here, we talk about behavior, like, for example, let's say you got drunk, right? Got drunk. Okay, take liquor, alcoholic drinks, you got drunk. That is, in other words, those behavior like drug addiction, intoxication by alcohol, could be diagnosed as madness, right? But the madness includes violent conduct, wandering around naked, talking nonsense or sleeps on the streets. So in each case, right, the respondent or the person itself qualified their description of psychotic behavior by saying that it occurred without reason. So it is called madness, right? So it's an uncontrolled abnormality. Uncontrolled. And how do you explain about this uncontrolled abnormality in the case of MET C, compartment C? So I wish to discuss a bit here, if I could refer to the legal perspective, right? For example, madness or insanity, right? So under Malaysian law, right, nothing is an offense under Section 84 Penal Code, act of person of unsound mind, right? So if you suffering from any psychiatric issues, psychiatric disorder, schizophrenia, whatever, it's not nothing is an offense which is done by a person who at the time of doing it by reason of unsoundness of mind is incapable of knowing the nature of the act, or that he is doing what is either wrong or contrary to law. Meaning what? Meaning that at the time you kill the person, you are under the influence of schizophrenia, for example. Okay, so at the time, okay, the time is a factor now. At the time you kill the person, you are under the influence of schizophrenia. So under Section 84, okay, you have committed the murder, but because of your schizophrenic symptoms, then it becomes nothing is an offense. So you can escape from being punished by the court, by the section itself. So how do you explain about intoxication? Okay, just now we were talking just now when I talk about this perception MET here, compartment C here, they call it uncontrolled abnormality. So what do you mean you're getting yourself, let's say you got drunk, right? Intoxication shall be a defense to any criminal charge, if by reason thereof the person charged at the time of the act or omission complained of did not know that such act or omission was wrong or did not know what he was doing. So that means if you look at under this particular section, sometimes when you got drunk, right? So you're not normal. Your mental state is actually not normal. So you're under the influence of alcohol. But can you use got drunk as a defense mechanism, as a defense in a court case under Section 85 and 2? So in this case, you look at B there. The person charged was by reason of intoxication insane. So the word here is intoxication insane. Dalam bahasa Melayu, mabuk itu tidak menjadi satu pembelaan. Jikalau mabuk itu tidak sampai kepada tahap gila. Itu maksudnya. Okay. So in a legal perspective, right? You claim that you are now in the category, you are under under the influence of alcohol. But if you still reckon, let's say you take 1 or 2 or 3 bottles of alcohol or wine, right? And suddenly you got drunk and then you kill the person. You claim that my mind is not sound. I was under the influence of the wine. But the issue here is, are you in the state of insane? Adakah anda berada di tahap gila? The answer could be no. So as long as you know where are you now, as long that you know that you are walking, you know that you can run, you know that who you are, even though you got drunk, okay, that kind of drunk, that kind of what I call this unsound mind or this mental disorder will not be qualified for this particular section. So that means you cannot escape from the charge if you kill the person. So even in a legal perspective, okay, the intoxication for a defense must be intoxication insane. Mestilah mabuk sampai tahap gila. Okay. So we need to tell them, you need to drink more bottles to make sure that you got drunk, not just got drunk, and you should be in the category of intoxication insane. Okay. And then zone D, you look at the zone D. Zone D is about uncontrolled normality. So uncontrolled normality. So how do you explain about this uncontrolled normality? Zone D, so we call it, this common called bad, BAD, bad. Certain other behaviors, uncontrolled by social norms, are still regarded by society as being normal, even though they are classified as socially undesirable and often legal. These are the behaviors classified as bad or criminal. In this case, the person convicted of a crime would be regarded as guilty, but as normal. The issue debated in their trial by lawyers and forensic psychiatrists would be the accused's awareness or lack of awareness of what the social norms of the society are, whether they had insight, were responsible for their actions, and knew right from wrong. Good example to explicate this will be crimes committed by minors. Statutory rape case. Under C, uncontrolled normality. Okay. Yeah, and this compartment D will be classified as bad or criminal. So how do you explain about uncontrolled but normal? Okay, you're talking about you're talking about awareness here. The issue of are you aware? Are you really understand the implication, or do you understand the consequences of your action? If you I would like to take this under the law case under Section 375 F Penal Code Malaysian law. You know, in Malaysia, if anybody committed a crime having a sex with a girl below 16 years of age, right? So having a sex, let's say an adult having a sex with a woman below 16 years of age. So whether with permission or without permission is considered as statutory rape. Because at this particular age, 16 and below, considered as a minor age. And the mens rea, or the mind of the children, or the victim, the children awareness of the implication will not be considered, will not be taken into account in the court. So those committed this, that means you have to face a charge of statutory rape, where the permission or the awareness of the mind of the children below 16 will not be counted. Okay, so this called uncontrolled, but in the category of normal, uncontrolled normality. Okay, so then this will be, I could say, examples of perceptions of social behavior. Okay, Dr. Janadi. Okay, I see 60 minutes already. Any questions from the students who would like to ask and so on? Otherwise, we're going to proceed.
Yeah, thank you very much for the excellent explanation given by the Professor Madya, Dr. Azlan. I say here that it's about this Etnomedicine also become the initial list, the focus of the attention anthropology regarding not Western, yeah, the symbol, and then the health, magic, and then Etnomedicine describe them the medical system and the different from the Western, the medical system, the modern, the classification, and then the single taxonomic, the unitary category in the contracts, the classification disease, and the traditional health system, and the limit and the effect disease and the characteristic, the different various the disease, and then I think that what is very good about this explanation, and then the analysis about this ethnopsychiatry about the support the patient request and to the understanding the reason, and then or the conflict between desire and the value, the context, and the assumption of the about life and the growth respond to the experience, and then anthropology based the listening and the sum, the informant, and then to understand the structure and the version and the symbol, including value and the basic assumption of the reality. I hope that there's here many questions, the question, the student and the related the topic. Please, the student, maybe ladies and gentlemen, if you have a question, please.
I saw one question in the chatting box. Right?
Okay,
maybe I could read here.
Okay, bro. Okay.
Dear Mr. Azlan, thank you. Okay, whatever. I have a question. Is it possible that there are certain cultural experiences that lead to mental disorders? And how does ethnomedicine, ethnopsychiatry deal with this? All right, this question is a good question, but I will answer this, when you see the following slides. Yes, of course, we have certain cultural experiences that lead to mental disorder, like in the case of Amo, the case of Koro, the case of grief, right? So how these cultural experiences talk about mental disorder, okay, and how these cultural issues can link and affect one's sound mind, okay. Inshallah, brother or sister, I will respond to this when you look at my further explanation on Koro, grief, and Amo, and that indirectly answers your question. All right, okay, inshallah, just inshallah, I will answer through my lecture, inshallah. Thank you. Okay, any more?
Okay, any more? Can you give a question?
Because after this, we're going to go to ethnographic description of psychiatric illness.
Okay, bro.
Okay, right.
Okay, bro.
Okay, no question? Okay, no question. Let's move on, inshallah. So the next topic will be on ethnographic description of psychiatric illness. This is the question stated in the chatting box just now. So what things to talk about under this topic, ethnographic description of the psychiatric illness? So let's look at, sorry, because I have to write this, but not to worry much. You can just focus the one written in red. Okay, and the American Psychiatric Association, in the fifth edition of DSM-5, they have listed grief as a mental illness. The issue here is about grief, ataupun berduka cita, grief as a mental. Do you consider grief as a mental illness? Right. So far, there's no conclusive scientific evidence to show what a normal length of bereavement is. So in this case, you can say when someone passes away and you are losing your loved ones, and then of course you will be in the category of grief, right? So this is experience. This is the one I took from Kleiman. So this is Professor Dr. Arthur Kleiman. So this is experience of Arthur Kleiman himself when his wife passed away. In March 2011, my wife died, and I experienced the physiology of grief. I felt greatly sad and yearned for her. I did not sleep well. When I returned to a now empty house, I became agitated. I also felt fatigued and had difficulty concentrating on my academic work. My weight declined owing to a newly indifferent appetite. This dark experience lightened over the months, so that the feelings became much less acute by around 6 months. But after 4 to 6 years of marriage, it will come as no surprise to most people that as I approach the first anniversary of my loss, I still feel sadness at times and harbor the sense that a part of me is gone forever. I'm not even sure my caregiving for my wife, who died of Alzheimer's disease, ended with her death. I'm still caring for our memories. Is there anything wrong or pathological with that? So Arthur Kleiman, he himself suffered he had this experience of physiology of grief. So under American Psychiatric Association in DSM-5, they are now classifying grief as a mental illness. So do we agree that grief as a mental illness? Right. So this is observation that this is a quotation coming from his own article, Clement. And let me move on. My own experience, together with my reading of literature, suggests caution is needed before we answer yes and turn ordinary grieving into a suitable target of therapeutic intervention. So that means we have to be very careful whether grief can be considered as mental illness or mental disease. That is the issue here. My grief, like that of millions of others, signaled the loss of something truly vital in my life. This pain was part of the remembering and maybe also the remaking. It punctuated the end of a time and a form of living and marked the transition to a new time, a different way of living. The suffering pushed me out of my ordinary day-to-day existence and called into question the meanings and values that animated our life. The cultural reframing, this is what I'm trying to say, held moral and religious significance. So the cultural reframing held at once subjective and shared with others in my life world. Cultural reframing held moral and religious significance. So we need to understand the concept of grief, not as a mental disease. We need to understand grief as within. We need to understand grief as a mental illness. It's not mental disease. So the key word here is cultural reframing. Framing of grief, okay, carries certain dimensions in terms of the moral and also the religious significance. Okay, I will explain in later, inshallah. Let's see what next. Okay, so what kind of so the issue here, the issue that I'm going to say here, the issue of normality versus abnormality in describing one's grief. So are you talking about culture framing or are you referring to religious framing? So cultural framing for meanings within context is imperative, is important. Such collective and personal process we usually refer to as culture is one sort of framing, a kind of master. So you are talking about, you need to understand grief as, when you say cultural framing of grief, we need to understand from the medical anthropological point of view, need to be understood as what? As a mental illness, not as a mental disease. So treatment for normal grief had to make it over into a disease, depression. So since there's no such no such protocol in the Western psychiatric model, the word grief, how to treat grief? How do you treat grief? So the only option left by the psychiatrists, they need to convert grief to another term, okay? Because there's no treatment for grief, but there is a treatment for depression. And this is what we call, according to Clement, this is what we call, this phenomenon of reframing a previously normal experience as a disease is called medicalization. To make it, if I could use the word, you try to medicalize the grief, right? So the normal grief, okay, it could be just a mental illness, but since there's no such treatment for the normal grief, so they decided to convert into depression. But depression, there is a treatment for depression. There is an anti-depressant drugs for depression. But grief, when you say grief, maybe your grief is not to a certain extent known as depression. It's not really depression. I'm not depressed of the situation. Just a grief. Okay. So this is something quite interesting for us to see. Let's look at in the Malay culture. How do we treat grief when someone passes away? And then of course you physiologically you are in the grief state. Among the Malays, we do have the chanting prayers. known as tahlil. Tahlil prayer. I'm not sure about Indonesia. Whether Indonesia do have tahlil. Okay, tahlil prayers. So when someone passes away, so all the members in the community will be gathering in one house, in the house, and start reciting Quran, start to do zikir, right? At the same time, try to comfort the family members. They say if the wife, in the family, the husband passed away, so we will try to comfort the wife. We say Allah knows better, is for His own good. So the comforting part, that means that's how the Malays treat the grief. Okay, I mean from the society itself. So we had the first night, the second night of Tahlil, third night, and then we leave her a while, and the seventh night we come back again, and the 40 nights, and then the final night will be 100 nights. So after 100 days of doing all this, what I call is on the 100th day of the Tahlil prayer, you can see there will be signs of improvement for the wife. Okay, maybe he got the husband, but husband passed away. So after 100 days, that's why I can see some of the Malays, they get to bring the wife to the graveyard and to put the gravestone, the tombstone on the grave. So once you are able to place the tombstone on the grave of your own husband, that means you initially or indirectly you are already recovered from grief, right? So this is one example about what I call ethnopsychiatric issues that we can talk about. And then the other one, we can also talk about Koro. What is Koro? Koro is largely considered to be a culture-specific psychiatric disorder, occurring primarily in South Asian cultures. The Koro is thought to derive from the Malay word kura, which means tortoise. The symbolic meaning that the penile retraction is compared with the retraction of the head of the tortoise into its shell. In India, it is known as Giniginia Bema, especially in Assam and West Bengal, where the Indian epidemic took place. So this is a case which I managed to quote from one of the articles. Miss J, a 21-year-old Indian unmarried female student who visited the psychiatry department, SSL hospital of our university in November 2011, and reported that 3 days back, while she was at her home, busy in studying, she experienced a sudden feeling of breast and genitalia shrinking associated with the fear of loss of womanhood and death induced by the thought that complete disappearance of the genital organ may result in loss of her womanhood and death. So that means in this case, the private parts of Miss J, okay, retracted. I mean, how to say, shrinking. It goes into the abdomen, and the breast also goes in shrinking into the abdomen. So automatically, when you have this situation, so Miss J got the fear of loss of womanhood. This can also affect his. This is also considered as a psychiatric problem faced by Miss J as a result of breast and her private parts disappear. Not say disappear, I mean it went through to the body. She was hopeless and helpless, but was eager and used to make repeated requests to her parents to get her married, thinking that after marriage her active sexual life may help her in some way or other. She was taken to a physician but did not get well. All right, this is another case of culture-bound syndrome, psychiatric issues called amok. Okay, so how do you explain about amok here? Okay, you can see Malays are a fighting race. That was how the British found them when they first came to Malaya. After the rulers had agreed to accept British protection, the Malays gave up fighting and became peaceful in their way of life. This does not mean that the spirit of fighting has died down. Normally, a Malay is polite and tactful, but one should not push him too far. The fighting spirit in him comes out again, and he is likely to run amok. Amok means that a Malay laboring under a grievance, either real or imagined, will go all out for revenge. And in the process, he puts very little value on his life. So he ran amok. Okay, amok is a kind of a term, right? Used to be that we can observe this amok in the Malay community. So based on the above description, do you agree the Malay amok, as described in the text, can be classified as psychiatric disorder? Of course, the answer is yes, right? So this is one of the disorder. Amok is one. Why? Okay, so these are the common characteristics of individuals who run amok. So of course, the person who run amok will be suffering from a psychotic depressive disorder, mood disorder, okay, bipolar. Okay, bipolar means that you can be good, so extremely good, or it can be extremely bad. It can be personality disorder, okay, with violent, so antisocial, right, violent action. Paranoid personality disorder, okay, you have delusion, right, of persecution and violent behavior. So that means you perceive harm. You feel that somebody is trying to kill you. Somebody is observing you. You feel that kind of situation. Paranoid personality disorder, right? Types of persecution. You tend to blame somebody is looking at me. Somebody is trying to kill me, right? In actual fact, it's nobody. Significant personal losses and psychosocial stresses. I'm sure this is, again, amok can be people can become amok, maybe due to certain things, okay? Maybe losing your job, okay? Personal losses, or maybe losing your loved ones, okay? It could be suicidal and homicidal behavior, okay? Anger and hopelessness, psychotic disorder with persecutory themes, okay, I already mentioned just now, paranoid schizophrenia, and so on. So these are the characteristics of amok. So amok can be considered as an example, is an example of abnormality in an ethnopsychiatric study classified as culture-bound syndrome, right? Culture-bound syndrome. So justification why amok can be considered as culture-bound syndrome. Why? Number one, because the psychiatric literature classifies amok as a culture-bound syndrome where culture was considered the predominant factor. Okay? It's a factor that contribute to amok. Amok involves suicidal and homicidal behavior, right? And the third point, okay, amok does not necessarily represent pathology. Okay, you don't talk about viral infection. You don't talk about amok in relation to bacteria or something to do with the viral infection. There's nothing to do with that, right? Not necessarily represent pathology. And then when we talk about amok, what kind of psychiatric issues that you're talking about here? So in this case, amok will be named as culture-bound syndrome because there is no special term, no standard psychiatric categories. Okay, the one that we have, the standard psychiatric categories that we have are inadequate, not good enough. And most of the culture-bound syndrome, including amok, are thought to be localized. That's why I can see anthropologists, they emphasize relativism rather than universalism. And number 6, culture-bound syndrome is a cross-cultural psychiatric pattern of behavior observed in a different society. All right. So this is amok. Okay, this is about the point number 4. I could say point number 4. Yes, talking about ethnographic cases. Okay, ethnographic cases, ethnographic description of psychiatric illness. So I've given the examples of Coro as an example of amok, and I did give examples of the concept of grief. How do you explain grief? But under American Psychiatric Association, they classify grief as a mental illness. Okay, so this is so far that we have done. All right. So I think we have one more to go, a few more slides to go, and I wish to talk about how. So we are talking about ethnopsychiatric, cross-cultural study, and so on. So how do you explain the psychiatric issues in this brings me to to the next step, to understand psychiatry in relation to law. Okay. How law defines psychiatry? What are the characteristics involved here? Okay. All right. So under law, okay, you can see here, psychiatric illness may occur. Okay. Right. Let me see. Okay. Sorry. So psychiatric illness may occur. Okay, may occur intentionally or from negligence. So these two words, right? Psychiatric illness may occur to a person, right? Intentionally, or I could say intentional in nature, or from negligence. Okay, how do you explain about intentional in nature? If the act is done intentionally, the principle in the case of Wilkinson versus Downton will apply. So that means we need to look at what principle that they use in understanding psychiatric issues in the category of done intentionally. Psychiatric illness includes all forms of mental illness, neurosis, and personality change that are medically recognized, right? So psychiatric illness, so under the law, okay, with all forms of mental illness, all forms of neurosis, and you're talking about personality change that are medically recognized. This must be differentiated from severe fear or emotional distress, grief, or sorrow, which by themselves do not give rise to liability. That means, as far as psychiatric illness is concerned, we need to draw the line to differentiate between psychiatric illness and from the severe fear or emotional distress or grief or sorrow, okay, which by themselves do not give to liability, except what? Except when those fear, when those distress, those grief, those sorrow leads to a physical illness such as hypertension, heart attack, or positive psychiatric illness such as anxiety, neurosis, or reactive depression. So in other words, as long as you got the fear, you are physiologically grieved, okay, you are so sad, you are sorrow, that alone is not enough. It's not good enough to support your argument that you are suffering from psychiatric illness. No. Okay. So psychiatric illness comes in when the one that you are suffering, stress, grief, fear, whatever, give or leads to hypertension, heart attack. Then it becomes a case. That kinds of psychiatric illness can be considered as a case now. So even though psychiatric illness in principle recoverable, the courts have always been reluctant and cautious in awarding compensation. So that means the whole text is saying that it's very difficult to measure or to quantify your psychiatric illness in terms of money, in monetary terms. How do you quantify? Some people say, I'm suffering from psychiatric illness, and because of that, I need 100,000. I suffer a mental disorder, so I need roughly around 2 million. So in this case, that kind of emotional disturbance, how do you measure? How do you gauge? And the answer is very difficult. That is why in the law cases, they don't talk about the fear, they don't talk about the grief. They talk about the relationship between the grief and your physical sickness. Let's say because you are suffering from some kind of stress, then you suffer heart attack. And that heart attack, okay, the medical bills to treat the heart attack can be quantified. So under the law, psychiatric illness alone is difficult to be quantified. But if psychiatric illness leads to physical illness, like heart attack, that can be quantified because the payment to treat heart attack, the bills that you use or the bills or the treatment that you pay for hypertension can be quantified. So that will be the message here. And then how do you, and then I did mention about the issue of liability here. How do you consider yourself, you are liable to the psychiatric illness? How do you measure your liability? This is another issues that can we talk about. Test of liability for psychiatric illness. The court laid down some guidelines related to the test of liability for psychiatric illness in McLaughlin versus O'Brien. In this case, the plaintiff's husband and 3 of their children were involved in the road accident caused by the defendant's negligence. Okay, so you just understand the narratives of the case. One of the children died, and the plaintiff's husband and 2 other children were seriously injured. The plaintiff was informed of the accident 2 hours after it happened, and upon arrival at the hospital, she was informed of the death of 1 of her children. She also saw the condition of her husband and the other 2 children, as a consequence of which she suffered nervous shock. Nervous shock is considered as psychiatric illness. Okay, it affects your mind, it affects your emotion, as well as your mind. The issue in question here, whether the nervous shock suffered by the plaintiff was reasonably foreseeable in the circumstances, taking into account that the plaintiff was not at the scene of the accident. So the issue here, I wish I could to summarize here, that under this case, one family met an accident. The husband and the children, not the wife. The wife was not there. And the wife was not in the car, and she was not involved in the accident. The accident took place only husband and their 2 children, and the children, sorry. So the wife was informed in the hospital, informed the wife 2 hours later of the accident. So she went to the hospital and she looked at her husband and the other 2 children. Okay, and she was informed that one of her children passed away. So she claimed that she got nervous shock. So the question now, do you consider nervous shock as a psychiatric illness or otherwise? So what will be the principle? What will be the principle used by from the legal perspective in understanding the psychiatric illness? Okay, so this will be what I call this the principle. Okay, I think this will be my final slide. I think, yeah. In the above case, the court decided through aftermath test and foreseeability of injury by shock alone was insufficient. So you say you are nervous shock. Saying that you are suffering from nervous shock alone is not enough, or does not does not guarantee for you to get the compensation. Okay, so your nervous shock must be reasonably foreseeable. Okay. Maksudnya secara munasabah tu, maknanya nervous shock itu secara munasabahnya dapat dijangkakan. Okay, dapat dijangkakan. Ataupun sesuatu nervous shock yang dialami oleh dia tidak dijangka secara munasabah. Itu maksud dalam bahasa Melayu. Reasonably foreseeable. So how do you define foreseeability here? So based on to define foreseeability, it must depend on the nature of relationship between the victims and the plaintiff or the wife. What will be the principle? Number 1, the class of persons who can sue is important. Persons who may claim must have a close emotional relationship with the primary victim. Meaning the first law, the first principle means the victim and the plaintiff is the wife, they are connected to each other. The victim is her husband. The children will be her children. So by right, because of the close emotional relationship, you consider this as a primary victim. So she has the right to claim for compensation for nervous shock because she is the wife of the victim. That would be number one. The second principle with physical proximity, meaning that under the law, psychiatric illness, whether you are allowed to file the case for the as a nervous shock and to claim for compensation, you need to prove this physical proximity. And physical proximity must be claimed under the concept of time and space. What do you mean by time? Okay, let's say when you were informed by the hospital that your family met an accident, the time for the wife to be in the hospital just within 2 hours. Within 2 hours, she was in the hospital. Meaning that considered as close, very close. But if you take 2 or 3 days to visit, that means that shows that you don't have a close relationship with the victim. It's clear, right? Let's say, for example, if my mother, okay, my late mother, suffers certain kind of disease, serious in the hospital. So automatically, I would just take, I would just go back and drive my car and go back immediately. In other words, I wouldn't be in a skeptical situation or I wouldn't hesitate. So I just go very quick as possible to meet my mom, right? So it's called time and space. And number three, the means. Where do you get this information? You get information from the primary context. I mean, the hospital informed the wife that your husband and children met an accident. So plenty comes upon the immediate aftermath. So the main is very important because you get the information from the hospital, not from the TV or from your colleagues. In other words, you are talking about first party, not third party. If you got the information through third party, then the chances of you to claim for the compensation as a nervous shock will be very much slim. And of course, of all these 1 to 3 items, I could say 3 important items. Yeah, the final part will be the most important part. Whether you are suffering from nervous shock or not nervous shock, okay, who will be able to verify that? The psychiatrist. Okay, finally, the defendant's negligence act must result in a psychiatric condition that is medically recognized. My meaning what? Meaning that the wife the court will say this particular person, the wife, needs to be observed by the psychiatrist. And the psychiatrist must prepare the report whether she is actually suffering from nervous shock or psychiatric illness in the category of nervous shock, right? This is from the legal perspective. Okay, I think again, based on all this presentation on ethnomedicine, ethnopsychiatry, I've done a bit on the psychiatry law. I talked a little bit on the ethnographic description of psychiatric illness. This is really a bit anthropological findings. We talk about these perceptions of behavior. All right, the concept of normality and abnormality. All right, and of course, I'm still talking about we're still using the same, what we call it, the same healthcare system. All right, I still retain this diagram. We're still talking about professional sector, folk sector, popular sector, even though you are suffering from psychiatric illness. These are the 3 sectors involved in addressing the psychiatric illness. All right, I think that's about it for my lecture, for today's lecture. I think I've taken almost 1 hour 40 minutes. Okay, so if there is any question, you are most welcome. Yeah, please, thank you. And I would like to thank again to Sipajaran Bandung for this great opportunity given to me to share issues related to medical anthropology, that is ethnomedicine and ethnopsychiatry. And of course, here we talk about the role of culture in the ethnopsychiatry issues. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Thank you.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, for explanation, Professor Dr. Mahdi Azlan. I think is no, yeah, there's no more question. Then is the time is the end. And then I can conclude today the lecture about this medicine is the result the indigenous culture development and then design from the conceptual framework, and then the modern medicine, and then the psychiatry about the approach is to the mental illness, to the listen and the patient and the understanding the structure, and then to the symptom, the original of the defined the site, and then this analysis support the patient. Okay, for the health anthropology course the next week, the lecture will still deliver Prof. Dr. Azlan. Yeah, I can thank you very much for Professor Mahdi Azlan, and then Mrs. and then Miss today, and also student. Thank you very much, Prof.
Ya, sebelum itu ada satu soalan ni. Selamat pagi. Ya, satu soalan. Selamat pagi Pak. Sebelumnya terima kasih atas. Saya Riawati Astuti, mahasiswi antropologi, bertanya, apakah fenomena koro sama dengan fenomena disunat jin di Indonesia? Oh, ini Dr. Ina.
Nah, iya itu pertanyaan itu belum terjawab.
Sama kah? Saya tak tahu yang disunat jin itu, saya tak tahu belum. Ada kah? Ada disunat jin? Disunat jin di Indonesia mengerti keduanya sama. Apa sama dengan koro di Indonesia? Saya tak tahu itu pasal disunat oleh jin.
Saya iring jawab saja. Pernah ada rumor seperti itu, tapi fakta sebenarnya saya tidak tahu juga. Tapi pernah ada cerita-cerita yang saya juga pernah dengar, tapi saya pada saat itu tidak terlalu kemudian memperhatikan lagi bahwa ada sunat oleh jin katanya.
Saya kali pertama dengar ni. Saya kali pertama dengar sunat oleh jin.
Iya, menarik itu.
Apa berjaya atau tidak itu?
Atau itu hanya di tingkat kepercayaan saja, atau entah bagaimana ya. Saya juga tidak mendalami Pak Azlan.
Ya, okey. Dr. Ina tahu pasal ni disunat oleh jin?
Yeah, we have heard about that story before. Usually this story comes out when a person break the rule. For example, they taking a pee under the secretary or something like that. Lalu
yes,
kemudian
exactly.
Tiba-tiba when he goes home, he got that situation. Jadi mungkin ini berkaitan juga dengan social control ya, dengan social control, dan mungkin juga untuk memperkuat kontrol sosial itu kemudian ada semacam mitos atau cerita untuk melarang orang melakukan sesuatu yang socially unacceptable begitu Pak Azlan. Jadi
apakah sama dengan apakah sama dengan koro sama dengan koro lainnya? Saya beda
kurang tahu juga ya. Mungkin gimana ya?
Mungkin gejalanya sama. Apa namanya?
Iya, gejalanya mungkin sama, tapi di balik itu mungkin meaning di balik itu nggak tahu apakah sama
ya,
atau
mungkin
berbeda.
filosofi di balik itu atau makna di balik itu yang berbeda gitu.
Ya. Saya pikir mungkin simptomnya sama tapi gejalanya sama tapi maksudnya agak berbeza.
Iya.
Yang ini yang disunat jin itu agak spiritual ya, spiritual.
Iya.
Okey, itu saja soalannya itu saja. Okey. Insyaallah. Thank you.
Yes, thank you Professor Dr. Mahdi Azlan. If there no question, we will end today lecture. Thank you very much for Professor Mahdi Dr. Azlan, Mrs. and Mrs. all and also student. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam, sama-sama. Terima kasih banyak.
Terima kasih, Dr. Azlan. Do you mind staying at the Zoom for a while because we have to discuss something with Ibu Wati?
Okay, insyaallah boleh.
Yeah, about the MOUN.
Oh, MOU. Okay.
Yeah, thank you.
I think we will discuss after the YouTube live is off.
Ya, mungkin dimatikan dulu oleh Pak Ujang ya.
Ya, boleh matikan YouTube live tu.
Otherwise, everybody will know our dapur. Ini ada pertanyaan. There's another question actually from Pak Edi Siswanto, Pak Bang Azlan.
Yeah.
But I think you can keep it, or you want for next week, or do you prefer to answer it now?
Apa MOU?
No. And in the chatting room, there is another question. Walau dominasi ilmu sains dalam perkembangan ilmu pengetahuan saat ini, namun dengan perkembangan sosial sebagai merebaknya pengaruh posmo saat ini, saya yakin ilmu kedokteran dan ilmu dan kesehatan akan mengalami evolusi dan tidak hanya memanipulasi fisik biologi saja, tapi juga melibatkan aspek-aspek antropologis dalam menuju manusia yang sehat. I don't know whether it's a question or just a statement.
Ini statement. Saya setuju. Saya setuju dengan apa yang ditulis tu. Ya, sama, saya setuju. Ya, itu aja.
Oke, terima kasih Pak Edi.
Terima kasih.
Pak Edi is our doctoral student.
Oh, okay.
He's working under Pak Junardi.
Oh, alhamdulillah Pak Junardi. Okay, alhamdulillah. Ya, okay. Ya, saya setuju Pak Edi sama.
Pak Ujang bisa tutup YouTube-nya, Pak Ujang? Belum ya?
Live tu, live streaming ya.
Live. Pak Ujang.
Sepertinya Pak Ujang nggak ada, Pak, harus ditelepon.
So, masih live streaming ya atau sudah?
Masih Prof. Masih live.
Matikan dulu Pak.
Oh, itu ada Pak Ujang.
Ya, oke.